Okay. So that's the reason why I added this topic in my important list. So yeah, let's begin. If you can see here, it's a clear cut. You don't have to worry about the signs, symptoms. They will directly give you a picture, or they will say that there's a lump near the opening of the vagina, and it is tender, right? Based on the sign symptoms, you will be easily able to understand. Okay, they are talking about the Bartholin cyst. Okay, so it will start as they will say that there is a patient with a vulval mass, right? So, so there's a vulval mass, and after that, you'll be pretty sure. Okay, maybe they are talking about what? Bartholin cyst, right? Whenever they talk about the Bartholin cyst, they always try to test you on the management part. Okay, so that means the management part for the Bartholin cyst is very important. But before that, let me tell you one thing, that if there's any patient whose age is more than 50 and there is a vulval mass, you have to go for the biopsy. It doesn't matter if the mass is infective, or if the mass is having any tenderness, or it is asymptomatic. You have to go for the biopsy, okay? Because it can be the vulval carcinoma, right? So you have to go for the biopsy in all those patients whose age is more than 50. This is the first thing which I want you to remember. After that, if there's any patient who is young and coming with such symptoms of Bartholin cyst, then what you will do is that you will check the size in the stem, right? Size is another important point which you should remember, that because this will change the approach. So size is very important, right? So if any patient with Bartholin cyst and the size is less than 3 centimeter, okay, less than 3 centimeter, then what you will check? Signs, symptoms of infection. Okay, you will check the signs, symptoms of infection. That is what you will remember over here. If the patient has signs, symptoms of infection, right? Like, let me just cut it over here. And yeah, so if the patient is having this vulval mass with Bartholin cyst and the size is less than 3 centimeters, then you will check up the signs, symptoms. After checking the signs, symptoms of infection, like for example, is there any tenderness or not? Okay, is there any tenderness? Is there any erythema? Okay, or is there any the patient's this vulval mass is warm? Okay, if there's any warmth or not. If such features are present, that means, if the answer is yes, if the answer to this question is yes, that means the patient is having infection. That means it's not a simple Bartholin cyst, it is an abscess. Okay, it is an abscess. So what you will see, you will say that okay, this is a case of Bartholin's abscess. It's a case of Bartholin's abscess. And how do you manage a patient who is having size of Bartholin's cyst of less than 3 centimeters with signs, symptoms of infection? Now you're pretty sure that the patient is having Bartholin's abscess. Now how do you manage them? You directly go for what? You have to go for the incision and drainage. In such patient, it doesn't matter the size is very small. You still have to go for the incision and drainage. After that, you will suggest that the patient to go for the sitz bath. Okay, so sitz bath is important over here, right? So what else you need to add? You need to add the antibiotics. Okay, you need to add the antibiotics because uh, the patient can have further complications if we don't use the antibiotics over here. If the size is less than 3 centimeter and there is no sign, symptom of infection, okay, this is a simple case of Bartholin cyst. This is not a Bartholin's abscess. This is a simple case of Bartholin cyst, and in all those patients you go for sitz bath, no incision and drainage. Okay, you go for the sitz bath and you ask the patient to go for the warm compressions. Okay, warm compressions. That's it. That's it. Now what about the other patients? All those patients who have a vulval mass, which is a suspected case of Bartholin cyst, and the size is more than 3 centimeter, which is also called as a large vulval mass. Okay. Now you're sure that the patient is having a vulval mass which is more than 3 centimeter. Now what you have to do is that next step is to check the signs symptoms of infection. Okay. Same signs symptoms of infection. What would be that? Tenderness, erythema, or the warmthness. That's it. If the answer to this question is yes, if the answer to this question is yes, then what is it? Bartholin's abscess. Okay, Bartholin's abscess. And what you have to do is that first step is you'll go for the incision and drainage. You do the incision, okay, you drain it, and then what you will put this word catheter, okay, and add the word catheter, okay. Word catheter is what you will add. Sometimes what they will ask you is that the patient is having Bartholin's abscess, and in what is the most appropriate step in such patients. In such patients, the most appropriate step would be word catheter. Remember that word catheter, inserting a word catheter, it's itself a long, it's itself as approach, or the you have to go for, it's a like basic criteria for inserting the word catheter. You have to do the incision and drainage. Sometimes what they will tell you, or they will give you in the options, is incision and drainage, and the other option would be the inserting word catheter. At the time you have to go for the word catheter, because word catheter is what will help the patient to drain all the abscess which is present in this Bartholin's gland. Okay, infected Bartholin's gland. So incision drainage, put the word catheter. That's the main thing. Word catheter is the main approach over here. Then you will ask the patient to go for the sitz bath. Okay, plus add the warm compressions and all. And then what you will ask the patient, you will give antibiotics to the patient and send home. That's it. What if the patient size is size of the Bartholin's gland is more than 3 centimeter, but there is no sign symptoms of infection? What you will do? What you will do is that here, if you check for a simple Bartholin cyst, which was less than 3 centimeter, we advise the patient to go for the sitz bath and the warm compression. But here, when it is more than 3 centimeter, it doesn't matter if the patient is having sign symptom or not. We have to go for the incision and drainage, but it should not be done alone. Plus, you will use word catheter. Never ever use incision and drainage alone. Never ever. Okay, you have to add the word catheter to it, and plus you will add sitz bath plus warm compression. Now the difference over here is that you don't give the antibiotics to the patient. Other than that, everything will be similar, which we have used in a patient who is having size of more than 3 centimeter with Bartholin's abscess, and you just added the antibiotics over here. But for a case who is not having Bartholin's abscess, a large Bartholin's abscess, which was a simple large Bartholin cyst, you just you just went for the incision drainage, then word catheter, followed by sitz bath and compression. Done. So it's not only this what you have to remember. Sometimes they just twist this thing, and what they do is that they will tell you that same patient came to you with a second episode. Okay, second episode of abscess, second episode of abscess. So in those cases who are presenting with the second episode of abscess, what you will do is that it will be simply treated by incision and drainage. You will repeat the incision and drainage, plus you will add what? Word catheter, and you will add antibiotics. This is a case of second episode of abscess. Then you will check whether it resolved or not. If it resolved, then you need not to do anything else. That's it. You will just discharge the patient on same antibiotics. That's it. But if it recurs again, okay, now that means it is the third time that the patient is coming with abscess, Bartholin's abscess. So here, after doing second incision drainage, a third time when she presents with the same sign symptoms or the recurrent Bartholin's abscess, you'll go for the marsupialization. Okay, plus you will add antibiotics. Done. Now you will check again if the abscess resolved or not. If it resolved, that's it. That's good for you. But if it recurs again, okay, if it recurs again, you will go for gland excision. Okay, gland excision. Any patient, even if sometimes what they will tell you is that they will give a stem where the patient has already went for the marsupialization, and then there is a second episode of Bartholin's abscess after marsupialization. At the time, you cannot go for the incision drainage. You directly go for the gland excision. Okay, you'll directly go for the incision drainage. Anytime a patient coming to you with Bartholin's abscess after marsupialization, you have to go for the gland excision. That's this is what you have to remember in Bartholin's cyst. Okay. Sometimes I have seen a question in your recalls. They say that yeah, this is basically near the in there will be the involvement of the Bartholin's gland. And I was checking over there in your email receipt. They say that it is more related with the labia minora, okay, rather than the majora. So you have to check the labia minora first, followed by the labia majora. Done. So labia minora is what you will check first, followed by the labia majora. Please remember this here, because this is the question which they may ask you in the exam. Then here comes a second case scenario of acute pancreatitis. I know that pancreatitis is again a very, it's a very tricky question which they ask in the exam, and particularly they ask about the usage of Atlanta's classification. Okay, where do we use the Atlanta's classification? That means when do we go for the ultrasonography? When do we go for the CT scan? This is what they ask you in the exam, and they will give you both the options in the uh, in the exam. Like the patient will have pancreatitis, and then they will give you in the options. There would be one of the option would be usage of ultrasound for the diagnosis, or usage of CT scan for the diagnosis. Okay, now we will discuss today how we will approach a case of acute pancreatitis. We know that the most common cause of acute pancreatitis. What is the most common cause of pancreatitis?
Alcohol.
Okay. Anyone else?
Bile, sorry,
Stone.
bile
Yeah,
stones,
bile.
bile stone.
Choledocholitis.
Mm-hmm. Okay.
Gallstone.
Colidoku. Yeah. The most common. This is one of the questions which they have asked. It is like pretty
Gallstone.
easy. Yeah. Gallstone. Okay. Gallstone is the most common cause of acute pancreatitis. Nearly about in 50% cases, those who come up with the acute pancreatitis, please rule out gallstone because it's the most common cause of acute pancreatitis. Why do alcohol cause acute pancreatitis? What is the reason?
Dehydration, maybe.
Mm-hmm. No, no. Like, for example, if there is a patient who is having diarrhea, they also have dehydration. Do they cause, do they land up in the acute pancreatitis?
Obstruction.
Okay, how? Obstruction, yeah, you're right, but how?
The gallstones will get stuck in the
That's with the gallstone. That's with the gallstone. I'm talking about the alcohol. How does alcohol cause pancreatitis? The reason being
The
is,
secretions being hampered.
see, the reason alcohol causes acute pancreatitis, the pathophysiology is related with the sphincter of Oddi, right? You remember, if for example, yeah, here we have a good picture over here. If you remember that there is the duct of pancreatic duct, it opens, okay, it opens near the duodenum, right, near the duodenum, and there is a sphincter over here that is called as sphincter of Oddi, right? You know, every patient who is taking alcohol, what does it result in? The contraction of, it results in the contraction of the sphincter of Oddi. And when there is contraction of sphincter of Oddi, all the secretion which is secreted by the pancreas, that gets over here, that accumulates over here, time by time, and eventually it results in the release, or it results in the inflammation, followed by what? Pancreatitis. That means the whole gland will be now inflamed, right? The reason being that the alcohol results in the acute pancreatitis is that it results in the contraction of sphincter of Oddi. All the accumulated pancreatic juice will now accumulate in the gland. Eventually, there will be inflammatory markers, inflammatory prostaglandins, interleukins will now increase, resulting in inflammation, and eventually the patient will have acute pancreatitis. Done. Every patient who is having, do you remember we have also discussed about the cardiovascular risk assessment, which is done by the Australian guidelines? There's a risk calculator.
Ostrich.
Yeah. If you remember, they say that any patient who has hypertriglyceridemia, okay, nearly about more than 7.5 millimoles, I'm not sure about it, but yeah, it is like pretty high. It is pretty high, like more than 7.5, we have to treat them. We don't go for the risk assessment, we directly treat them. The reason being is that hypertriglyceridemia results in pancreatitis. If you'll see a patient in your clinic and the patient is having hypercholesterolemia, right, the patient is having hypercholesterolemia, we treat the patient. We don't wait for anything. We give rosuvastatin, we give the statins, right? But when there is a patient who is having hypertriglyceridemia, initially we don't do anything until and unless it is pretty high, like more than 4 millimoles, right? After that, we start using the medical treatment for the hypertriglyceridemia. If we talk about the milligrams per deciliter, when it's more than 500 milligrams per deciliter, then we think about the treatments. Okay, we then use the fibrates and all. But and over there, the reason is that after 500 milligrams per deciliter, it starts accumulating on the pancreas, resulting in acute pancreatitis. Okay, that is the reason why do we use medical treatment after 500 milligrams or 7.5 millimoles in a patient who is coming with hypertriglyceridemia. The reason being is that hypertriglyceridemia itself results in the acute pancreatitis. Okay, but yeah, for your exam, gallstone is important, alcohol is important. Okay, choledocholitis. Eventually, the patients who have gallstone, they get into the choledocholitis. Then this stone can drop down into the pancreatic duct, eventually resulting in the acute pancreatitis. Done. So yeah, mumps. Those patients who have mumps, okay, remember two things with the mumps. Number one is orchitis, okay, orchitis, and the other one is gallstone. Any patient who is having who is having mumps, please rule out orchitis and the gallstone. Okay, orchitis and the gallstone, because if you remember, the epididymo orchitis is most commonly caused in sexually active people by chlamydia, right? For that reason, we use doxycycline. But you need to take the history in every patient, whether they had any bilateral parotid gland enlargement and all, because or there was a case of like sore throat and other things, because those patients will, after 5 to 6 days, okay, they may have orchitis and you don't use doxycycline in them. So mumps, always try to rule out orchitis and gallstone. Okay, once we are done with this, now we can go for the sign symptoms. What are the sign symptoms? Typical sign symptom of acute pancreatitis, because that's used in the Atlanta's classification. This is what they
Epigastric
ask.
pain radiating to the
Yes,
epigastric pain
yeah,
radiating to the
that's
back.
epigastric pain, which is
Radiating to back.
radiating to back. Exactly. Plus, the patient will have nausea, vomiting, right? Nausea, vomiting. And with that, if it is a mild acute pancreatitis, it won't have any complications, right? It won't have any complications. But when it is a moderate to severe acute pancreatitis, it can result in multi organ dysfunction syndrome. But yeah, you, for your exam, just forget about that. But one of the complications of acute pancreatitis, if there's a patient with the acute pancreatitis, one of the complication could be either formation of abscess, right, or pseudocyst. So pseudocyst or abscess, right? This is the complication. Now, before that, let's talk about, now there's a patient coming with epigastric pain and nausea, vomiting, right? Nausea, vomiting, and epigastric pain. What is the next step? Next step.
Ultrasound.
Okay, you can go for the ultrasound.
Serum amylase lipase.
Yes, you can go for the serum lipase is more important for us than the serum amylase. Now, now tell me one thing. If we have, if there is a patient, if there is a patient with epigastric pain, which is radiating to back, okay, which is radiating to back, and there is a raised serum lipase. Is there any need of going for the ultrasonography? For
No,
your,
sir.
yes, the reason is, so for those patients who have epigastric pain with raised serum lipase, we can skip the usage of ultrasonography. Okay, this is basically your pesky exam question or MC clinical exam question. Any patient with epigastric pain and raised serum lipase, you can skip the radiological investigation. The reason being is we use a criteria that is what we call as Atlanta's classification. Okay, Atlanta's classification for diagnosis of acute pancreatitis. Okay, acute pancreatitis. They say that if there is a patient with abdominal pain, okay, which is classical for acute pancreatitis, that is epigastric to, which is radiating to back, plus, or the patient is having serum lipase more than 3 times elevated. Third one is we can go for abdominal imaging. Okay, abdominal imaging for acute pancreatitis. Please remember this. For acute pancreatitis, you use ultrasonography, and for chronic pancreatitis, you use CT scan. Okay, when to go for the CT scan, I will tell you. But yeah, according to Atlanta's classification, we have these three points by which we can diagnose a patient who is having acute pancreatitis. Now, remember that according to Atlanta's classification, if any of these two are positive, that is a case of acute pancreatitis, and you can skip the ultrasonography. But yeah, sometimes recently in May 2025, they asked you a question in which the patient was having acute pancreatitis, classical case scenario of acute pancreatitis with raised serum lipase, and then they gave the then they ask you what is the most appropriate next investigation for the diagnosis of this patient. Okay, at the time you can go for the ultrasonography, but remember that if it's a patient who came up with epigastric vein which is radiating to back, and he came up to you or he showed up in your clinic after 48 hour. Okay, after 48 hour, what you do is that you don't use ultrasonography, rather you go for CT scan. Okay, rather you go for CT scan. But yeah, there's a trick. Remember that if the patient is coming after 48 hours and the patient is having signs symptoms of acute pancreatitis, and in the question, if they have said that this is a raised serum lipase, remember that in chronic pancreatitis, the serum lipase would be normal. Okay, it would be normal. So therefore, even if he is coming after 48 hours and they have given you that the serum lipase is raised, you still have to go for the ultrasonography. At the time, you don't go for the CT scan. But if it's coming after 48 hours and the serum lipase is normal, okay, at the time you can go for the CT scan. Clear with this? Please let me know if you are clear with this, then we can move forward, because this
Sir,
is the
can you
question.
please repeat? Just a bit
I'm
confusion
saying
between all
that,
of us.
yes, I'm saying that if there is a patient who is coming to you with sign symptoms of pancreatitis, that means epigastric pain which is radiating to back. If he is coming to you in less than 48 hours, okay, you have to use ultrasonography. Number one, if he is coming to you after 48 hours, but the serum lipase is raised, okay, and then they asked you, and then they ask you what is the investigation of choice, or what is the radiological investigation which we can do in this patient for the diagnosis, it is still ultrasonography. But if they ask you that the patient came up to you after 48 hours and the serum lipase, they have not mentioned about the serum lipase, that means you have to assume that the patient serum lipase is normal, or they will directly tell you that the serum lipase is normal plus normal serum lipase. What you will do, you go for the CT scan. Done?
Sir, as a next step, we'll do CT scan for the third one, right? More than 48 hours
Yes,
plus
yes,
normal levels.
yes.
That's the next step.
Yeah,
Why not USG, sir? Like, why are we skipping that?
because any patient who is coming to you after 48 hours with sign symptoms of pancreatitis, epigastric pain radiating to back with normal serum lipase, that means the acute phase has resolved. Now you are looking for the complications. Okay, now you are looking for the complications of the acute pancreatitis which it has already resulted in, and for that reason ultrasonography would not be definitive, or it won't help you in that. So for that reason you go for the CT scan. Okay.
Under, Understood, sir. Thank you.
Okay, this is how they will ask you the investigation part in the acute pancreatitis. Now what is the management for acute pancreatitis? You put the patient on NPO, okay, and you give IV fluids and you give analgesics. Okay, you use analgesics. You can, if the patient is having hypertriglyceridemia, you will treat that. Okay, if the patient is having hypocalcemia, okay, you will treat that. You need to mention the hypocalcemia also, because there is a calcium which will deposit on the pancreas. Hypercalcemia, right? Hypercalcemia, when the patient is having hypercalcemia, it itself can result in the acute pancreatitis. But hypocalcemia means if the patient is having hypocalcemia and on the CT scan or ultrasonography, you are suspecting, more important in on the CT scan, you are suspecting that the pancreas is deposited with calcium. You have to also make sure that you will treat hypocalcemia also. Forget about the hypercalcemia part. I'm talking about the hypocalcemia. If the patient is having acute pancreatitis with hypocalcemia, you have to treat that. Okay. Now, one important point which I want you to mention, which I want you to remember is that if there is any patient, for example, mm, let me put it here. Now, for example, if there is a patient, who is coming to you with uh, painless jaundice. Okay, painless jaundice. If any patient who is coming to you painless jaundice in your exam, and the patient is elderly, okay, what is the first thing which should come up in your mind? First thing,
Purvisier's law, pancreatic head carcinoma.
Pancreatic cancer.
yeah, this is what exactly they have asked frequently in your exam, but people don't recall this very question because this is so simple and they miss it. Sometimes the very basic question which comes up in the exam, we tend to miss it, and we don't remember that, okay, what was that question. We assume that that was very complex, but sometimes it's very simple. Patient coming to you with painless jaundice and the patient is elderly, you have to think about the pancreatic cancer. Pancreatic cancer. Okay, you have to think about pancreatic cancer. Now, another important point. If there is a patient who is having, I will talk about the choledocholithiasis also. If the patient is there and he is having choledocholithiasis, that is, there is a stone. Okay, there is a stone which is present in what? Common bile duct, right? If this is the liver and this is the hepatic ducts, and then there is a common hepatic duct. This is the gallbladder, cystic duct, and now there will be common bile duct. And if the patient is having stone over here, this is what we called as choledocholithiasis, right? And in the patient who is having choledocholithiasis, there is a Charcot striate, right? Which I have mentioned yesterday. Patient will have jaundice. Patient will have pain, abdominal pain with fever, right? Now you are pretty sure that the patient is having what? Choledocholithiasis. Now, uh, what was the investigation which we do in such cases? ERCP, right? ERCP. Now you went for the ERCP. After the ERCP, the patient is coming to you with nausea, vomiting. Like you went for the ERCP, you treated the patient, right? After few days, now he's coming to you after few days. Okay, after few days, he's coming to you with nausea, vomiting, and epigastric pain. What does this suggest?
Iatrogenic
Uh,
because of endoscopy.
yeah, iatrogenic what?
This is blocking the the duct, pancreatic duct. That's why
Yeah,
patient develops
this is
acute pancreatitis,
acute pancreatitis. Exactly.
sphincter of body.
So basically, if you read the complications of the ERCP itself results in the acute pancreatitis. Okay, read about the ERCP, read about the acute pancreatitis. There is a mnemonic of get smashed, which are the causes of acute pancreatitis, and one of them is ERCP. ERCP itself results in the acute pancreatitis. So any patient who has went for the ERCP and coming to you after few days of ERCP with nausea, vomiting, and epigastric pain, please rule out what? Acute pancreatitis. Exactly, like you have already mentioned that this is a case of acute pancreatitis and it's one of the complication of ERCP. Now you will do what? Next investigation is that you will go for serum lipase. You will check the serum lipase and definitely it will be elevated. Okay, and this is your answer. This is your answer. What is the most appropriate next step in a patient post ERCP coming with nausea, vomiting, and epigastric pain? What is the next most appropriate step? You will go for the serum lipase checkup. Okay, and you will use the treatment protocol for these pancreatitis patients as same as which you have done for the gallstone patients resulting in acute pancreatitis. That's NPO, IV fluids, and analgesics. I mentioned the triglyceridemia and the hypocalcemia. CT scan after 48 hours. Done. Okay. Now I was talking about the painless jaundice in elderly patient. This is a case of pancreatic cancer until proven otherwise. Any patient who is coming to you painless jaundice is a and if the patient is elderly is a case of it's a case of pancreatic cancer until proven otherwise. And once such patients comes to you, if there is any patient who is coming to you with painless jaundice and is elderly, you have to suspect the pancreatic cancer. The other symptoms which could be related with it is anorexia and of course the weight loss, right? Weight loss. Now, tell me about the investigation. Investigation. What should be the investigation we should do in such patients?
Ultrasound?
Yeah. See, this is where they trick you. Either you, because I know the confusion arises whether we go for the ultrasound or we go for the CT scan. But as I already mentioned, the patient has painless jaundice, and when I say painless jaundice, you go for the CT scan. Okay, you go for the CT scan. There is a protocol which is called as pancreas protocol CT scan. Okay, for that reason, you go for they say that the initial modality for the pancreatic cancer for a suspected case of pancreatic cancer is CT scan. CT scan. Then when do we go for uh, what do we say, ultrasonography? If you're suspecting that the patient is having pancreatic cancer, right? If the patient is having pancreatic cancer, when do we use ultrasonography? When the patient will have, if the patient is having, you are suspecting that the patient is having pancreatic cancer, but it is painful, painful jaundice. Okay, painful jaundice. Like for example, the patient is also complaining of abdominal pain with jaundice, or the patient is having, because you have to initially look for, even if there is anorexia and weight loss and now you're suspecting there is cancer related with it, the patient is having any carcinoma, but still you have to use the ultrasonography at that time to rule out maybe this is more related with the common bile duct, or it is a carcinoma of what? It can be the carcinoma of gallbladder also, even though you may suspect that the patient is having uh, pancreatic carcinoma rather than any gallbladder carcinoma, or the any carcinoma which is related with the common bile duct. So painful jaundice, go for ultrasonography. Done with this. Once we are done with CT scan, okay, here come to this painless jaundice. Once we are done with the CT scan, you go for then ERCP, okay, which is most preferred diagnostic tool for the pancreatic carcinoma. But remember that. But remember that if the patient has went for any, like for example, there's a patient who had a previous history of say for example there was a stomach cancer or whatever it is. The patient had obesity, and the patient went for the any bypass surgery. For all those cases, you cannot use ERCP. Okay, you cannot use ERCP in those patients who have, like, there is altered anatomy of the gut or the intestine. Okay, and in such cases you will use MRCP. And this is your MCQ. Patient with painless jaundice, the doctor went for the CT scan. Once the doctor went for the CT scan, it was suggestive of that the patient is having pancreatic carcinoma. What is the most appropriate next step? And in the history, the patient had a previous history of bypass surgery for the weight loss, right? And what is the most appropriate next step? If you will go for the ERCP, that's wrong, because all those patients who have altered anatomy of intestine or stomach or the gut, you have to go for MRCP. Other than that, go for the ERCP in other cases. Clear with this? Okay.
Yes.
Now, another case scenario where there is a patient with anorexia, nausea, and weight loss. Please remember, any patient who is coming to you with anorexia, nausea, and weight loss, and they will add up for the for making this very question easy for you, they will add up that the patient is spilling out, okay, whatever he's eating. Okay, whatever he's eating, the patient is spilling out that. It the spillage. Okay, they will say that, they will mention that whatever he's eating, he's spilling out same. It's a raw thing which he's spilling out. Okay, so spilling means he is vomiting with a raw with the raw food or whatever he eats. That means it is suggestive of there is a gastric outlet obstruction. But yeah, remember that this undigested food which he is spilling out, it is basically it is suggestive of advanced uh, stomach cancer. It is suggestive of advanced stomach carcinoma. So just remember one thing, that patient with anorexia, nausea, and weight loss, the first thing, and the patient is having a small sign symptom of like GERD. At the time, make sure, yeah, you will think about the esophageal carcinoma, but yeah, the first thing which you need to see is that whether the patient is having any stomach cancer or not. Okay, stomach cancer. Rule out this first. So when we talk about the stomach cells, okay, stomach cells, we have, either we have gland in the stomach or we have connective tissue, right? And in the stomach we have other two things, and that is either we have lymphatics or we have hormone secreting cells, right? Now, based on that, we have differentiated the type of carcinoma. If the patients develop carcinoma in the glandular cells, it is what we call as adenocarcinoma, and which is the most common type of stomach carcinoma. If the patient develops carcinoma in the connective tissue or in the interstitial, that is what we call as GIST. gastrointestinal stromal tumor, just right. The treatment of choice for this is, just remember that we go for the tyrosine kinase inhibitors. Okay. Like for example, all those drugs which end up with tinib, okay, like the ponatinib and all. Okay, so this will end up over here. You don't have to remember this. Just if they ask you about the gist, go for the any drug which is a tyrosine kinase inhibitor, like ending with the tinib. But the other one is the lymphatics. If the patient is developing the cancer which is related with the lymphatics, that is lymphoma, right? Lymphoma. And if he's developing the cancer from the hormone secreting cells, that is carcinoid. Okay. And for the carcinoid, remember that the marker will be 5-hydroxytryptophan. Okay, 5-hydroxytryptophan. This is your MCQ. They will just ask you, they will just tell you that the patient is coming to you with flushing of the face, with anorexia, nausea, and weight loss, and there is elevated 5-hydroxytryptophan. Make sure they are going to go for the carcinoid tumor of the stomach. Okay. So simple. What was the initial features? The patient's earliest sign symptoms for the stomach cancer would be anorexia. Please don't skip whatever I'm discussing, because all these questions have been asked and people don't recall these questions. Anorexia and nausea. Okay, anorexia and nausea. These are the earliest sign symptoms. Plus, the patient will have weight loss also. Okay, this is what we called as a triad of stomach cancer. Triad of stomach cancer. Okay, stomach cancer. Triad of stomach cancer. Later, the patient can have mechanical obstruction where the patient will spill out or vomit out the undigested food, right? And the risk factor is if the age is more than 60, the patient is a smoker, the patient is taking alcohol, or the patient is having any family history of stomach cancer, or there is he has been infected with the H. pylori. There is a chronic infection of H. pylori resulting in chronic gastritis and then resulting in the lymphoma and all, or gastroma, or the patient is obese. All these are the risk factors for the gastric carcinoma. Gastric carcinoma. And once you are pretty sure that the patient is having gastric carcinoma, okay, what is the diagnosis? What is the investigation which you'll use for the diagnosis? Simple question. You'll,
Endoscopy with biopsy.
you'll go for endoscopy plus biopsy. And when they ask about the treatment, it is just simple surgical excision. Okay, if you have diagnosed it early. But remember that if it has if there is metastasis, then at the time you have to go for the chemotherapy. For your exam, just remember that surgery, you have to go for the surgery. Done. So once we are done with this, you go for a patient, will approach a patient who is having right upper quadrant pain. Now tell me, what are the differentials if the patient is having right upper quadrant pain? First differential, only that we will discuss.
Gallstones.
Exactly. The patient who is coming to us with right upper quadrant pain, the first thing is we will mention or we will think about gallstone. Okay, gallstone. That means we are discussing about, that means we have to rule out pathology related with what? Gallbladder. Right? Gallbladder. There's a pathology which is related with the gallbladder. That is what we will discuss first. And the first thing which we'll do is that even if there's a patient who is coming to you with right upper quadrant pain in your clinic, you always you always advise the patient to go for ultrasonography, right? That is the first thing you do, isn't it? So you'll go for the first initial step is to go for ultrasonography. And if this patient is having, either the patient can have a gallstone, okay, either the patient is having gallstone in the what we called as gallbladder, that is called as cholelithiasis. There is cholelithiasis of the gallbladder. Forget about that the patient can have acute cholecystitis due to the gallstone. We will discuss about that. But yeah, before that, we just have a simple picture that patient with right upper quadrant pain, first step, go for the ultrasonography. Now, if the ultrasonography is showing the gallstone, okay, gallstone, later on the definitive management is we go for the laparoscopic cholecystectomy, right? Laparoscopic cholecystectomy. But if the patient is not having any gallbladder stone, no gallbladder stone, okay, what do we need to do next? The next step is we have to exclude other pathologies. Exclude other pathologies. Exclude the other pathologies. With that, you go for the HIDA scan. Okay, HIDA scan. It is nothing but hepatobiliary immunoacidic scan, where you will just use this immunoacidic where you will use this immunodiacetic contrast. And what do you do is that you will check the ejection fraction of, if this is the gallbladder and this is the bile which is stored in it. Normally the ejection fraction, once it is contracted, right, once it contracts, basically what happens is that the real thing is, if this is the stomach, okay, and this is the duodenum, right, this is the duodenum, and here we have the pancreas, isn't it? Once we eat any fatty meal and it reaches near the first part of the duodenum, right, first part of the duodenum, there is release of a cholecystokinin, right, CK. And this CK is responsible for contraction of gallbladder. It goes and contracts the gallbladder. It tells the gallbladder, hey, I got some fat over here, please emulsify it. So gallbladder, it contracts, and there is release of what, bile acid into the cystic duct, followed by the common bile duct, then pancreatic duct. All those juices mix up, and then it's released into the minor duodenal papilla, right? Minor duodenal papilla, which is present over here. Done. And then it emulsifies the fat, whatever was present. And this ejection fraction, okay, it's not only the ejection fraction which is used in the heart, the ejection fraction in the gallbladder, it should be more than 30% at least. But if it is less than 30%, that means the contraction of the gallbladder is weak. So in on HIDA scan, if the ejection fraction is less than 30%, right, that means the contraction of the gallbladder is weak. At that time, you again have to go for the laparoscopic cholecystectomy. Laparoscopic cholecystectomy. Either the reason is there is any obstruction over here, that is the reason it is not having a good ejection fraction, or the gallbladder is weak, right, for its contraction. Therefore, all those patients who have less than 30 ejection fraction, on HIDA scan, you go for the laparoscopic cholecystectomy. Laparoscopic cholecystectomy. Done. So this is how you approach a simple case of right upper quadrant pain. Ultrasonography, gallstone, go for the laparoscopic cholecystectomy. No, it's not a gallstone, go for the HIDA scan and exclude the other pathologies also. Check the ejection fraction. If the ejection fraction is less than 30, go for the laparoscopic cholecystectomy again. With that, now we will discuss about none other than our case of acute cholecystitis. Because whenever whenever there is a patient who is having this, if this is the gallbladder, if this is the gallbladder, and the patient is having stone over here, okay, the patient is having stone over here, stone in the neck of, which is also called a Murphy's pouch. The patient is having stone in the neck of the cystic duct, right? There's a Murphy's pouch, most common site where this stone lodges. Now, what will happen is that all the bile which is present over here, it cannot it cannot be emptied. Right now, it will start accumulating over here, resulting in inflammatory condition. And once there is inflammation of this gallbladder, that is what we called as acute cholecystitis. The patients who have acute cholecystitis, they come up with right upper quadrant pain, right? Right upper quadrant pain. The patient can have fever, patient can have nausea and vomiting, patient can have Murphy sign positive, okay? Murphy sign positive with inflammatory markers which would be raised. This is a case of acute cholecystitis caused by a calculus. That is what we called as acute cholecystitis due to calculus, due to gallstone. But there are some possibilities in which there is acute cholecystitis not due to the stone. No calculus is found. That those cases are called as acalculous cholecystitis. Acalculous acute cholecystitis. Now, what is the reason for acalculous cholecystitis? What is the reason for acalculous cholecystitis? That means without any stone, you went for the ultrasonography. There was no stone present over here, there, but still the patient's gallbladder is thickened. The mucosa is thickened. Okay, there is thickness of the gallbladder. There is thickness of gallbladder like more than 5 mm. Okay, what could be the possibility of that?
Lack
What is
of
the
contractions.
sorry?
Lack of contractions.
Okay,
Like, yeah.
okay. There is dysfunction. There is dysfunction of the gallbladder. But what is the like? Who are those patients in which there is dysfunctioning of the gallbladder? Dysfunctioning with the emptying of gallbladder. Who are those patients? Such questions are like basically asked in your exam. Plus, they are definitely, if you go for the pesky exam, the first question for the acute cholecystitis patient case scenario, this is the first thing which they will ask. A patient with the cholecystitis, and you went for the ultrasonography, but the patient is not having any gallstone present over there, and now you're suspecting that the patient is having acalculous cholecystitis. What could be the reason? What could be the possibility? Dysfunctioning of the gallbladder, right? But what results in the who are those patients in which this dysfunction of the gallbladder is present? It is most commonly seen in those patients who are either they are burn patients, okay, or they are on TPN, total parenteral nutrition. Like, for example, there's a patient who is having any severe injury, or the patient is having malnutrition, and now we are using the TPN, or there is a patient who is in ICU. All these patients, they have a high risk for the acalculous acute cholecystitis. And the sign symptoms would be same: right upper quadrant pain, fever, nausea, vomiting, Murphy sign positive. Okay, Murphy sign positive. So these patients, what we have to do? These patients, they definitely they are also treated as same as the acute cholecystitis due to the calculus. Now, the another important point is that then they will ask you about the initial assessment. Initial assessment in such cases. Initial assessment in such cases. What is the initial assessment which is done in these cases after you have diagnosed, okay, maybe it's a case of a calculus or the calculus cholecystitis? What is the initial assessment? Of course, the initial assessment is you will check the Murphy sign. Definitely, you will go for the full blood count, right? You will go for the CBC and all. You will check the LFTs. Remember that any patient with acute cholecystitis, please check the LFTs also. Please check LFTs also. Okay, before doing surgery, make sure the LFTs are normal. Make sure the LFTs are normal. So once you went for the FBC, once you went for the LFT, once you went for the ECG is also done in these patients. That means the pre-op procedure is this. And after that, once the patient has went for the initial assessment, you already have went for the imaging. Is there any usage of X-ray in a patient with acute cholecystitis? The answer is no. No usage. Okay, there is no use of X-ray in a patient who has acute cholecystitis. This should be in your mind. After that, for the management part, we use a criteria which is called as sepsis 6 protocol. Okay, sepsis 6 protocol. That means if the patient is having a high degree fever, like SIRS criteria. Remember SIRS criteria? What is SIRS, SIRS criteria? Systemic inflammatory response syndrome, right? So, anyone from you who can tell me about the SIRS criteria? What are the points in the SIRS where we suspect that the patient is having sepsis? This is basically used for the sepsis.
Temperature is more than 30, 38.5, like high temperature.
Okay.
And the heart rate is more than 100.
Heart rate is more than 100. And
And hypotension.
okay.
And
Mhm. See, let me tell you one thing. This simple mnemonic for the SIRS. This is if you are going to go for the exam and you don't know SIRS, because the SIRS is used in a patient who is having diabetic ulcer, right? The patient who is having cellulitis, any patient who is having neutropenia, a neutropenic sepsis, the patient who is in shock, or the patient is having septic shock. The patient here, we again having any severe infection, like we have to rule out the sepsis in these patients also. And for that reason, we have to know the SIRS. The SIRS criteria says any patient who is following throw criteria. It's not any throw is not nothing. It's not any like it is not used in the textbooks. Throw is basically a mnemonic which is used to remember for the SIRS. THRO Okay. T is your temperature. Any patient who is having temperature of, remember this point, more than 38 degree or less than 36. Okay, less than 36. Any patient with heart rate of more than 90, I guess. Okay, and respiratory rate. Any patient who is having raised respiratory rate more than 24 or more than 20. O is nothing. W is WBCs. Any patient who is having WBC of either less than 4K or more than 12K. Okay, these are included in your search criteria. Now, they say that any patient who are fulfilling any of these two criteria or 2 points, right? they are suspected to have sepsis. They are suspected to have sepsis. So if we use this search criteria over here, right, the patient is having, for example, raise 38 degrees Celsius, the patient is having tachycardia. For this reason, it is having two positive among the SIRS, plus uh, there is a foci of infection. We have to use the sepsis 6 protocol. For this reason, we use IV fluids, we use IV antibiotics, okay, we use oxygen. We have to administer the oxygen also. If the patient saturation is decreasing, we have to measure the urine output. We have to take blood culture, okay, take the blood culture also. Now once you had done this, now you will approach for whether the patient had calculus acute cholecystitis or acalculous cholecystitis, okay. If the patient has calculus cholecystitis, the antibiotics which are used are, please remember this, okay, please remember this, any patient who is having acute cholecystitis due to the calculus, the antibiotics which are used are A, G, and M. What is AGM? AGM means A is your amoxicillin, same. It is amoxicillin, gentamicin plus metronidazole. Same thing which you'll use for the acalculus and the calculus. Okay, same thing. But there is one trick. Sometimes they will give you a patient who is having myasthenia gravis. Okay, the patient having myasthenia gravis, that means the muscle weakness. Okay, muscle weakness due to the antibodies which are related with the acetylcholine receptors, and the patient is having muscle weakness towards the end of the day, right? Towards the end of the day, the more work he does, the more weakness in the muscle is present in those patients. There's drooping of eyelid, there's generalized muscle weakness and all. With that, if patient is coming to you with acute cholecystitis, which of the following drug should not be used among amoxicillin, gentamicin, and metronidazole? Which of the following drugs should not be used in a patient who is having myasthenia gravis? It is gentamicin. Okay, gentamicin is aminoglycoside drug, and if you read the aminoglycoside drugs, it results in it's one of the side effect is it results in the myasthenia gravis. Okay, it blocks the receptors of the acetylcholine. So for that reason, if the patient is having myasthenia gravis and coming up to us with acute cholecystitis, we have to use piperacillin plus tazobactam. Okay, go for your recalls and definitely you will find this very question. Okay, you'll find this very question in the April 2025. They have asked this very question. If the patient is having, or in the e-medicine, you will definitely find this question. The patient is having acute cholecystitis and the patient is having what do we say, myasthenia gravis, and either it is calculus or acalculus, we have to go for the piperacillin tazobactam because gentamicin cannot be used in all those cases. Now this is where you all of us get confused. Okay, all of us get confused. Now how do you approach patient with symptoms of cholelithiasis, right? That is right upper quadrant pain. You went for the ultrasonography and all. See, first step, ultrasonography. Now you'll assess the predictors of concurrent choledocholithiasis. Choledocholithiasis, don't get confused where we use this ERCP, where we use the MRCP. Now it will be very simple for us. Patient who is having, we have to assess the predictors of the concurrent choledocholithiasis. Now we will assess it. If the patient has, if the patient is coming in moderate or strong or the very strong, assessment or the predictors for the choledocholithiasis. Accordingly, we'll see whether we go for the MRCP or ERCP. For that reason, I just want you to remember the last one. That is very strong one. Okay. Any patient who is having sign symptoms, who is having cholelithiasis, and then you have to choose between uh, whether we go for the ERCP or MRCP after ultrasonography. Please look at these 3 points. If there is a patient who is having CBD stone visualized, that means you went for the ultrasonography and it is showing common bile duct stone, then you directly go for the ERCP. Any patient who has clinical signs of acute cholangitis, okay, clinical signs of acute cholangitis, that means Charcot's triad, okay, you go for directly ERCP. Any patient who is having a bilirubin of more than 4, please remember this, more than 4, you go for ERCP. Other than that, every patient you should go for the MRCP. Done? Is it clear now where we go for the ERCP and MRCP? Don't make your life complicated. Just remember the last one and everything will be easy, because other than that, you have to go for the MRCP. Done with this? Okay. Mm, yes. Now, let's discuss about the benign prostatic hyperplasia. Okay, benign prostatic hyperplasia. Again, important question for your exam. Now, what is the definition? Simple definition. Any patient who is having benign prostatic hyperplasia, that means there is glandular proliferation of the there is proliferation of glandular epithelial tissue. There is proliferation of smooth muscles and the connective tissue within the prostatic transition zone, sorry, okay, not the peripheral zone, it is a transition zone. If there is any involvement in the peripheral region of the prostate, that means it is more related with the prostatic carcinoma rather than the any benign prostatic hyperplasia. So prostatic transition zone is more for benign prostatic hyperplasia. Once you have you know the definition, everyone knows about the definition, we have to know about the complications. The complications are potential complications of untreated BPH. Okay, it's untreated BPH. It includes acute urinary retention. In addition, chronic obstruction and failure of completely emptying the bladder of urine can increase the risk of urinary tract infections, bladder stones, formation of bladder diverticuli, and the renal damage. Please remember this, renal damage. Very important for your exam. Why? Because they will give you a case scenario of benign prostatic hyperplasia, then they will ask you about the next step. And then in this next step, in the options, you won't find anything which is related with the benign prostatic hyperplasia if you don't know that we have to check the creatinine in such patients who are having benign prostatic hyperplasia. Because if it results in the bladder outlet obstruction, there is a reflex. Okay, the reflex will go up and it may result in the kidney scarring. Okay, renal scarring. So eventually there would be renal damage. In order to assess that, in order to evaluate that, you have to go for this creatinine, you have to check the creatinine. Then what is the clinical presentation? This was the complication of no, if you have not treated a case of benign prostatic hyperplasia. Remember that BPH can be asymptomatic, in which cases it does not require treatment. Okay, BPH may lead to enlargement of prostate, that is benign prostatic enlargement, and results in lower urinary tract infection due to the obstruction at the level of bladder neck. If you remember, if this is the bladder, if this is the bladder, right? This is the bladder, and this is where the prostate is present, right? And this is the prostatic urethra, which is the urethra. This is the bladder. This is the bladder, and this is the prostatic urethra. Prostatic urethra, and if you can see the prostatic urethra, it passes through the prostate. Now imagine if there is a hyperplasia of this uh, prostate, of course the patient will have difficulty in the passage of urine. He cannot pass the urine easily. Therefore, there will be accumulation of this urine in the bladder, right? And this will go up and can result in the involvement of the kidney also. Okay, so yeah, that is the reason. Also, when there's accumulation of urine in the bladder, it can result in the cystitis, that is the UTI, simple cystitis. Then after that, remember that if the patient is having lower urinary tract symptoms, BPH includes, what does it include? Storage, irritative symptoms will be there, like urinary frequency will be there, urgency will be there, nocturia will be there, and incontinence. How do you remember? Any patient with FUND, that is, frequency is increased, there is urinary frequency is increased, urgency is over there, okay, N is the nocturia, and D is the dysuria. If I add the dysuria, it is more towards the UTI. If I remove the dysuria in it, it is all these fun, FUN, frequency, urgency, and nocturia. It is related with the benign prostatic hyperplasia. Voiding symptoms. There will be slow urinary stream, straining to void, stream starting and stopping during micturition, or hesitancy, splitting of voiding stream. Okay, this is very, very vague kind of clue which they may give you in the exam. Splitting of widening stream. Splitting of widening stream. There will be like just like these two splits of urine passage. Okay, once the patient starts passage of urine starts widening, there will be splitting. There will be two streams. That is suggestive of uh, initial stages of the benign prostatic hyperplasia. Now, for the diagnosis, you go for the history, you take the history and go for the physical examination. Physical examination, it including DRE, where you will see non-tender and large prostate, non-tender. Okay, the prostate will be enlarged and it will be diffusely enlarged. There won't be any nodular pattern. If there is nodular pattern, think about the prostatic carcinoma. We'll discuss that tomorrow. If there is on the DRE, if there is nodular enlargement, think about the prostatic carcinoma. If there is a non-tender with diffusely enlarged prostate, think about the benign prostatic hyperplasia. The size of the prostate on examination does not correlate well with symptom severity. The International Prostate Symptom Score, widening diary, and if renal damage suspected, you have to go for the electrolyte, you have to go for the urea electrolyte and the creatinine checkup, you have to go for the bladder scan, and you have to go for the renal ultrasound to see if there is any renal damage or hydronephrosis and all. Post-wide residual volume measurement, it is basically less than 12 milliliters is normal. Okay. Now, usage of prostate-specific antigens in BPH. PSA testing is not needed for the diagnosis. Then, if they ask you that the patient is having benign prostatic hyperplasia, and one of the option is then PSA for the diagnosis, definitely you will not go for that because PSA is not useful for the BPH. But it can be used as a proxy for prostatic volume when considering usage of 5 alpha reductase inhibitor. Okay, when there is the this widening, okay, this post wide residual volume is more than 250 ml at the time before usage of 5 alpha reductase inhibitor, okay, like finasteride, dutasteride, you have to use what, you have to check the PSA again. If there is a patient who is having post wide residual volume of more than 250, okay, more than 250, before commencing 5 alpha or before starting 5 alpha reductase inhibitor like finasteride, dutasteride, you have to check the PSA levels. You have to check what, PSA levels. These medications are also useful in men whose prostates are above 35 grams, okay, 35 grams, which correlates with PSA of more than 1.5 nanograms per deciliter. Any patient whose prostate is enlarged and it is more than 35 grams, Okay, above 35 grams, you can start what? 5 alpha reductase inhibitor. But remember one thing, if there is a patient who is on like tamsulosin, okay, tamsulosin, and you use the tamsulosin and it failed, okay, it failed. The patient is having there's persistent sign symptoms of benign prostatic hyperplasia. The second drug which will add is 5 alpha reductase inhibitor, that is finasteride or dutasteride. Initially, if the patient is having 35 grams of prostate, or the PSA level is 1.5 nanograms per deciliter, with the usage of tamsulosin, okay, you will add in from the initial while starting the treatment, you will add the finasteride or the 5 alpha reductase inhibitor with the tamsulosin. Okay, what is the criteria? If it is more than 35 grams. But if there is less than 35 grams and you started with the tamsulosin, but the patient is not having the sign symptoms under decrease, there is a persistent sign symptoms, then after that you can add the 5 alpha reductase inhibitors. Okay, what is when do we go for the usage of PSA? If the patient has if you are starting the 5 alpha reductase inhibitor, and before that you have to go for the you have to go for the PSA checkup, or the patient is having prostate enlargement that is more than 35 grams, you at the time you can also use PSA, because you have to use the 5 alpha reductase inhibitors in those patients also. Patients with erectile dysfunction. If there is a patient who is having benign prostatic hyperplasia, and with that the patient is having erectile dysfunction, phosphodiesterase type 5 inhibitors like sildenafil, tadalafil can be used. Patient with overactive bladder symptoms like anticholinergics can be used for patients in whom there is like onset of like frequency, urgency, and incontinency. Okay, if these are predominated, you have to use the anticholinergic, oxybutynin and all. Surgical. What is the usage of transurethral resection of the prostate? Basically, it is what we call as endoscopic prostatectomy, and it is the gold standard surgical treatment for symptomatic BPH. If you have used tamsulosin, if you have used 5 alpha reductase inhibitor, but still the patient sign symptom is not decreasing, for that reason you have to go for the transurethral resection of prostate. This is one of the usage of or indication for the usage of transurethral resection of prostate. Okay, minimally invasive surgical therapies, forget about this. But yeah, you have to use, where do you use this transurethral resection of prostate? If the medical treatment, pharmacological treatment fails. Now, what are the uh, complications of complications of um, transurethral resection of prostate? Anyone, just tell me one of the most famous complication of transurethral resection of prostate.
Dilutional hyponatremia.
Dilation of,
Hyponatremia.
yes, yeah, that's what we call as TERP syndrome, right? But yeah, this one, it is rare, but yeah, it can happen, and it is hydrogenic due to the excess usage of NS while you doing the surgery. Yes, due to the irrigation and all. Now, what is the complication of TERP? What are the other complications? Forget about, because I have already written over this here. Like, but what are the other complications of transurethral resection of prostate?
Retrograde ejaculation.
Yes, this is what I was. Yeah, that is retrograde ejaculation. This is what I was waiting for. Retrograde ejaculation. Retrograde ejaculation is one of the commonest complication of transurethral resection of prostate. Other than that, there could be bleeding, right? There could be bleeding. There could be urethral stricture. Please remember this. Any patient who is coming to you, any patient who is coming to you with urethral stricture, right? Any patient who is coming to you with sign symptoms of benign prostatic hyperplasia after doing TURP, and he's coming to you with same sign symptoms which he was presenting before, like dribbling of urine, difficulty in voiding. Please remember that that could be due to this urethral stricture. Please remember that that could be due to urethral stricture. Let me repeat this again. If there is any patient who is coming to you with same symptoms, sign symptoms of BPH even after the usage of TURP, think about the urethral stricture. Now, what are the sign symptoms of urethral stricture? It is just like the BPH. Like, for example, the patient will talk about that I'm having difficulty in passage of urine, I'm having dribbling, I'm having increased frequency, nocturia, and all. And in those cases, please remember that it could be due to what? It could be urethral stricture. Now, thinking about the TURP syndrome, now we'll talk about the TURP syndrome. TURP syndrome is a rare but potentially life-threatening complication of transurethral resection of prostate. It occurs as a consequence of absorption of fluids used to irrigate the bladder during the operation. One of the doctors already mentioned this, into the prostatic venous sinuses. Signs and symptoms and okay, signs and symptoms are varied and unpredictable and results from fluid overload and disturbed electrolyte balance like hyponatremia. In particularly, the clinical picture of TURP syndrome will vary according to its severity and may further be influenced by the type of irrigant used. There is no classical presentation for TURP syndrome. Indeed, signs and symptoms are often vague and non-specific. Remember that there could be involvement there because basically there is involvement of the CNS. So patient will come up with CNS manifestations like restlessness, headache, nausea, vomiting, confusion. Very important, confusion, visual disturbance, cerebral edema, convulsions, and the coma, or the patient is having cardiopulmonary systemic manifestations like bradycardia, hypo or hypertension, tachypnea, hypoxia, cyanosis, pulmonary edema, systemic manifestation like hypothermia, abdominal pain, and distension. So basically, all are related with the due to the hyponatremia. Okay, due to the hyponatremia, particularly all these symptoms which are coming up, there is basically this hyponatremia which results in the restlessness, headache, nausea, vomiting, or all the sign symptoms which are related with the central nervous system. So yeah, make sure any patient who is coming to you with constipation, exactly, constipation is again one of the complication of transurethral resection of prostate. Okay, this procedure. And with that, okay, I'm seeing that if there is any patient who went for the TURP and now he's coming to you after he's coming to you like, or after the procedure he's having confusion. Okay, only with confusion you can say that the patient can have TURP syndrome. You have to rule out this first. Go for the electrolyte checkup. Patient will have a hyponatremia and treat that. Okay, that's it. Now, uh, PSA, usage of PSA again. PSA should be measured prior to initiation of the uh, treatment with 5-alpha reductase inhibitor. I already mentioned this, right? As such, the treatment may lower PSA levels typically by 0.5 nanograms per deciliter and influence further prostate cancer screening. We have to use the prostate cancer screening. Please go for to the red book. Moderate to severe lower urinary tract symptoms is associated with an increased incidence of acute urinary retention. Okay, normal men have less than 12 ml of residual volume, but most urologists are not concerned unless the post-void residual volume is greater than 250. And you do you remember when I said that those patients who have a post-void residual volume of more than 250, that is suggestive of we have to use this 5-alpha reductase inhibitor, and before you start 5-alpha reductase inhibitor you do PSA. The diagnosis does not require histological confirmation. Prostatic biopsy is only warranted if there is concern about prostatic cancer, such as asymmetry, as I mentioned, or nodular gland on DRE. Done? See? Nodular gland. Or an increased rising prostatic specific antigen. Now, these are the some of the indications for the urological referral, where the patient can have severe symptoms of pain, men who are less than 45-year-old, hematuria, dysuria, then incontinence, neurological disease, urinary retention, or suspicion of other urological diseases. Now, initial investigations in general practice settings. This is what most of the questions for you would be. I know that they say that this is an intern level examination, but most of the questions coming up in your exam, they would be like taken from the RACGP. See, if you'll see the initial investigations in the GP settings, because what are the guidelines which you use for the exam? RACGP, right? RACGP, most of your questions will be solved by using RACGP. And if you can see over here, while they say initial investigations for a patient who is coming to us with the benign prostatic hyperplasia, they have written over there, see, urinalysis and then what? Serum creatinine. Serum creatinine is very, very important for a patient who is coming to us with benign prostatic hyperplasia. Okay, of course, we'll think about the urinary tract ultrasound, or later on, we can think about the prostate specific antigen, and this is the criteria where you will use prostatic specific antigens. Clear with this? Now, someone, Dr. Muazzam, I guess, he was asking about the acute GI bleeding, right? Acute GI bleeding. Please remember, if there is a patient who is coming to you with acute GI bleeding and the patient is unstable, you have to go for what? DRS ABC protocol. Okay, DRS ABC protocol. That is what we already know. With that, we can use endoscopy, flexible sigmoidoscopy, because flexible sigmoidoscopy is very long rather than the rigid one. And what if the patient had any, you know, the patient is very prone to have the perforation and all. For that reason, we cannot go for the rigid. And rigid is very small, like nearly about, it is nearly about 20 centimeters, 16 centimeters. It can just look for the sigmoid only. But the flexible sigmoidoscopy, it can even check the cecum also, like the right colon also, more than 60 centimeters. Then catheter angiography or laparotomy. So this part is very simple for us. Hemodynamically unstable, and you are able to stabilize the patient, or the patient is having acute GI bleeding and he is hemodynamically stable. Now, for this question, you have to know one important point. If the patient is having acute GI bleeding, and the GI bleeding is, like, for example, coming up as hemoptysis, sorry, the hematemesis, that is vomiting with like bloody vomiting, right? For all those cases, you use upper GI investigation first, that is, you will go for the endoscopy, right? All those patients who have lower GI bleeding, right, there is bloody stool, okay, because you will suspect that the patient can have any carcinoma or whatever it is, angiodysplasia. The patient can have diverticulitis, so diverticulosis, as previously mentioned. For those cases, you go for colonoscopy. So, but sometimes there is melena, right? There is melena, which is basically your upper GI bleeding, right? Upper GI bleeding, the upper and lower GI bleeding, it is basically defined by the ligament of Treitz, okay, which is nearly present near the duodenojejunal junction. There's a ligament of Treitz, and it says that they say that any bleeding which is above ligament of Treitz, it is considered as upper GI bleeding, and any bleeding which is below this ligament of Treitz, it is called as lower GI bleeding. Okay, lower GI bleeding. Sometimes, if the patient is having upper GI bleeding, whether it is variceal or non-variceal bleeding, please watch my lectures on the GI. It is available on the site. Okay, you just need to click on the links, and you can, learn about the upper GI bleeding if you have time for your exam. But yeah, this pattern, this session is more exam focused, and eventually you will be able to answer if there's any question related with the upper or lower GI bleeding. So what I was saying is that sometimes this upper GI bleeding, okay, instead of coming with the vomiting or through the upper GI tract, it will go down, okay, and during the during its tract, it will be oxidized, and the patient will have a blackish blood, okay, blackish blood, and that is what we called as melena, right? Any patient who is having melena, you will go for upper GI bleeding, upper GI investigation, that is endoscopy first, rather than the colonoscopy. But again, there is a twist. If the patient is having melena, please make sure, if the patient is having upper GI symptoms, like for example signs symptoms of reflux, GERD, patient is having dyspepsia, okay, or gastroenteritis, the patient is, sorry, not the gastroenteritis, patient is having dyspepsia, patient is having signs symptoms of GERD or epigastric pain, okay, for that reason you go for the first endoscopy. But remember, if there is a patient who is having just a simple melena and the patient is complaining of a lower, you're suspecting that the patient is having melena, okay, and the patient is having lower abdominal pain, or the patient is having constipation, okay, this constipation, lower abdominal pain is more towards the lower GI, right? Lower GI. Therefore, you will go for the colonoscopy first. Please just tell me if I am clear with this. Well,
Can you repeat it, doctor?
see, what I'm saying is that while you are choosing endoscopy and colonoscopy, okay, it is very simple. If the patient is having upper GI symptoms, like for example, patient is having GERD symptoms, reflex, heartburn, or whatever it is, okay, the patient is having dysphagia, or the patient is having epigastric pain, okay, plus if the patient is having melena, even with these symptoms, you will go for the endoscopy, okay, you will go for the endoscopy. But if the patient is having melena, we know that melena is basically your upper GI bleeding, it is not the lower GI bleeding. Melena is basically most commonly seen in, it is upper GI bleeding, but it comes with the stool, it is a blackish blood, okay, blackish appearance. And for that reason, if the patient with the melena is having lower abdominal pain or constipation, that means lower GI symptoms, for all those cases, you will go for the colonoscopy, not the endoscopy first. Okay, because the patient is having sign symptoms which are more related with lower GI. If patient comes up with the melena and upper GI, go for the endoscopy. Patient with melena and lower GI, go with the colonoscopy first, because you need to choose between the colonoscopy, endoscopy, right? So where we use the endoscopy and where we use the colonoscopy, this is what I am discussing about. Again, patient with upper GI symptoms, let me make it very simple. Any patient, whatever it is, even if the patient is having melena, patient with melena, okay, or sorry, plus the patient is having upper GI symptoms, first thing you will go for the endoscopy. Patient with melena plus lower GI symptoms like constipation, like the lower abdominal pain, go for colonoscopy first. Or the patient is having change in bowel habit, like for example the patient is having tenesmus, patient will tell you that, I'm not able to pass out the stools easily. It seems like some of the stool is still present in my intestine and I'm not able to pass out that, okay. So change in bowel habit. So all these cases you have to go for the colonoscopy first. Now again, patient with hemodynamically stable, okay, check out the upper, is it the upper GI bleeding or the lower GI bleeding. If it is upper GI bleeding, that is hematemesis, okay, hematemesis, go for the endoscopy directly. If the patient is having lower GI bleeding, like the bloody stools like seen in the colorectal carcinoma, go for the, or even the hemorrhoids, go for the colonoscopy. Okay, once you are done with this, now case found and treatment attempted endoscopically. You found out that the patient is having variceal bleeding or there is an ulcer in the stomach. While doing the endoscopy, you will treat that. Okay, successfully, and the treatment is successful and the bleeding stopped. Once the bleeding stopped, you will go for the interval follow up. You will go for the interval follow up. If this bleeding cannot be stopped, okay, unsuccessful and bleeding continues, is it a variceal bleeding or non-variceal bleeding? If it is a variceal bleeding, you will consider the tips or the surgical shunt. If it's a non-variceal bleeding, you will repeat the endoscopy with the specialist decision. Here you just need to remember that after you have after there is an unsuccessful treatment of the upper GI bleeding, initially you will repeat the endoscopy. You'll repeat the endoscopy. That's it. Now come here. Now if the patient went for the colonoscopy, right, the patient has, for example, change in bowel habits, and the patient is now having bloody stools, that is hematochezia, and you went for the colonoscopy. You went for the colonoscopy. Now remember that this is your question. Okay, you went for the colonoscopy. If the patient is having, it is active GI bleeding. Okay, remember that. Actively he is bleeding. You went for the colonoscopy and cause cannot be found or colonoscopy is not feasible. Is not feasible, go for the CT angiogram. This is MCQ. 100%. Okay. This is your MCQ. When do we go for the CT angiogram? If we went for the colonoscopy, or the if we went for the colonoscopy and you are not able to find out the cause of acute GI bleeding, okay, then at that time you have to go for the CT angiogram. Or the colonoscopy is not feasible, you go for CT angiogram. Cause is found, go for the interval follow up. Cause is not found and bleeding is intermittently, go for the RBC scintigraphy. They have never asked any question at this very level. They are just asking you a question which is related with the CT angiogram. Now, if they ask you in the next very exam, if they will ask you about CT angiogram is already done, what is the next investigation? It is RBC scintigraphy. It is RBC scintigraphy. Done? Done with this? Sometimes I, f- I just want to go back and I want to mention about this cholecystitis. Remember that once you have treated the patient, okay, you went for the amoxicillin and this, and now the fever is settled. And now what you will do? You will go for the laparoscopic cholecystectomy, right? You will go for the laparoscopic cholecystectomy. Patient with acute cholecystitis, you went for the initial assessment, you use the sepsis 6 protocol, IV fluids, antibiotics, and all. Now the patient's fever has settled. After that, you will go for laparoscopic cholecystectomy. Okay, as soon as possible. Like it, they say that within 2 days, okay, the fever should settle and you should go for the laparoscopic cholecystectomy. But sometimes, but sometimes, what happens is that what happens is that the patient has a recent MI, for example, or the patient has a severe comorbidity like heart failure or whatever it is, and the patient needs to go for the cholecystectomy. What is the other possibility which we can use? It is what we call as percutaneous cholecystostomy. Okay, cholecystostomy. Okay, what is the usage of percutaneous cholecystostomy? Normally, in most cases, patient would undergo for the cholecystectomy, right? during admission, and ideally within 2 days of admission, like after you have settled the sepsis and all. But in patients with comorbidity, for example, obesity, okay, like more than 40 BMI, severe obesity, or the patient is having uncontrolled hypertension, like for example more than 160 or more than 110, patient is having any heart failure, okay. So for that reason, you have to go for percutaneous cholecystostomy. You have to go for what? Percutaneous cholecystostomy, or other than uh, cholecystectomy, okay. Because I have seen one question on this percutaneous cholecystostomy. Where do you go for? Because simple case, if the patient is having any what? If the patient is having any uh, a severe comorbidity, for all those cases, you go for the percutaneous cholecystostomy. Okay. Now, the last one is your, mm, it is your carotid artery stent. Okay, carotid artery stent. Sorry, carotid artery stenosis. So, if you remember that, we have this common carotid artery, and then it divides into external and the internal common carotid artery, isn't it? That is simple for us. If there is, if there is a patient who is having signs symptoms of stroke, whether it is transient ischemic attack or the stroke, okay, first thing is to rule out whether the patient is having any carotid artery stenosis or not. Like for example, there's a patient who comes up with TIA, like there is ischemic neurological symptoms that resolves completely within 24 hours. Like for example, the patient has amaurosis fugosis, the patient had a blackout, the patient had a transient the patient had a transient facial weakness, patient has a transient blindness, okay. And after within 24 hours everything got resolved. That is a case of transient ischemic attack, isn't it? Now, in all those patients, the first thing you should do is that you have to check the carotid artery stenosis. Carotid artery stenosis. So, the carotid artery stenosis is caused by the atherosclerosis. Okay, it's caused by atherosclerosis, and sometimes the patients are asymptomatic, and you hear a bruit. Okay, there is a bruit, and due to that, the presence of bruit, you go for the ultrasonography, duplex ultrasonography of the carotid artery, and you will check the stenosis, isn't it? You check the stenosis, and once the patient is having stenosis, then you will manage the patient according to the according to the amount of stenosis. What is the what is the percentage of stenosis in the patient, right? So remember that. What are the symptoms of stroke? uh, the symptoms of TI or stroke can include drooping of one side of your face, slurred speech, loosening of vision in one eye, loosening of feeling on one side of your body, losing muscle strength, and having weakness on one side of your body. We don't have any problem with that. If the patient is having these symptoms, which are only for more than which are only for 24 hours, that means less than 24 hours, this is called as TIA. If they are there for more than 24 hours, it is what we call as stroke. And those patients who have carotid artery stenosis, they have ischemic stroke, not the hemorrhagic stroke. Okay, done. Simple. This is what we already know. Now, talking about imaging, this carotid artery duplex ultrasonography, it remains the first line investigation. Okay, any patient with TIA, and you have to rule out that your carotid artery stenosis, go for the duplex ultrasonography. Done with this? Okay. Now here is the thing which they ask in your exam. That is the approach. Patient with suspected carotid artery stenosis, go for the duplex ultrasonography. Stenosis detected, any degree. What is the type of degree? It doesn't matter. The initial treatment starts with lifestyle modification, lipid lowering therapy, and the antiplatelet therapy. Please remember this, antiplatelet therapy. Okay, antiplatelet therapy. Any patient, doesn't matter. The patient having stenosis, it doesn't matter what type, what degree of stenosis, you have to use three drugs: lifestyle modification, lipid lowering therapy, and antiplatelet therapy. Now, if the patient, let me erase this, okay? If the patient is having this stenosis, which is less than 50%, okay? Less than 50%. If it is less than 50%, it doesn't matter whether the patient is asymptomatic or symptomatic. You have to go for observation. Not the observation, you will just discharge the patient. Okay, because the revascularization, that is end arterectomy, is not required. Okay, clear with this? Patient, carotid artery stenosis, any degree, use the lifestyle modification, lipid lowering therapy, and antiplatelet therapy. And degree is less than 50, discharge the patient. But if the degree is more than 50%, more than 50%, and the patient is symptomatic, asymptomatic, patient does not have any symptoms, it was incidentally, you found out that the patient is having bruit and you advised the patient to go for the duplex ultrasonography. The patient is not having any TIA symptoms, or the patient had not any previous TIA symptoms, okay, or carotid artery stenosis symptoms. You incidentally, or you went for the duplex ultrasonography by your own choice after checking the bruit. Now the patient is asymptomatic. Now it will depend on the degree of stenosis where you go for the revascularization, or you will observe the patient, or you just give the lifestyle modification or lipid lowering therapy, or put the patient on the antiplatelet therapy. Now, asymptomatic patient, this is the American guidelines. That's the reason I have not included over here. Patient with carotid artery stenosis and is asymptomatic, if the degree of stenosis is less than 80, discharge the patient, follow up the patient on these drugs. Okay. If it is more than 80, if it is more than 80, go for the revascularization, even if the patient is asymptomatic. Clear with this? Done. Now, if the patient is having stenosis which is more than 50, and the patient is having symptoms, okay, patient is having symptoms, check now. If it is moderate stenosis, that is 50 to 69, okay, you have to consider the revascularization, only indicated if benefits outweighs the risks. Most of the times we go for the endarterectomy. Okay, initially we start the antiplatelet therapy, followed by we have to consider the elective revascularization within 6 weeks. Patient with severe stenosis and had symptoms, go for the revascularization. And severe stenosis is 70 to 99%, and that is the modality used is carotid endarterectomy. That is the first line. If you cannot use this, go for carotid artery stent. If you cannot use that, go for the carotid artery bypass graft. First line is carotid endarterectomy. Simple case scenario is, if their patient is having carotid artery stenosis, suspected case of carotid artery stenosis, you go for the duplex ultrasonography. Once you go for the duplex ultrasonography, it doesn't matter the patient, the degree of, what is the degree of stenosis. You put the patient on lifestyle modification, you give the patient antiplatelet therapy, okay, you give the patient lipid lowering therapy, okay. After that, you check the degree of stenosis. If the degree of stenosis is less than 50, you discharge the patient. Okay, if it is more than 50, okay, if it's more than 50, then you will see whether the patient's is asymptomatic or symptomatic. If the patient is asymptomatic and the degree of stenosis is less than 80, you discharge the patient on same drugs. But if it is more than 80, if it is more than 80, what you will do? You will go for the revascularization. Now, if the patient is having symptoms and more than 50, okay, you treat the patient with a revascularization. That's it. Okay, that's it for the carotid artery stenosis. So here you can read a reasonable approach for a general practice point of view is to refer the asymptomatic patients with an internal carotid artery stenosis of more than 80% for a non-urgent vascular surgical review for consideration of surgery. Now, for asymptomatic patients with internal carotid artery stenosis of less than 80%, a referral is usually not required. Done. Key points. Carotid artery stenosis is a major cause of acute ischemic stroke. The disease can be classified as asymptomatic or symptomatic based on correlation of disease with the recent stroke or TIA. Patient presenting with acute neurological ischemia or amaurosis fugax, which may be a manifestation of symptomatic carotid artery stenosis, should be promptly referred to an emergency department or discuss directly with the vascular surgical service, because any patient who is having signs symptoms of carotid artery stenosis like amaurosis fugax and all, it is a symptomatic carotid artery stenosis. You go for the Doppler ultrasonography. If it is more than 50%, you go for the surgical treatment. That's the vascular surgery referral. Then patients with symptomatic carotid artery stenosis should be commenced on the antiplatelet therapy, very important, and considered for surgery. Patients with the asymptomatic carotid artery stenosis should be commenced on the BMT with referral to vascular surgical services when the degree of stenosis exceeds 80%. Okay, again 80%. 80%, go for the surgical procedure. The degree of stenosis less than 80%, yearly surveillance. Okay, a yearly surveillance with carotid Doppler ultrasonography is appropriate. Then carotid endarterectomy is a gold standard for the surgical management of symptomatic carotid artery stenosis and should ideally be carried out within 2 weeks. Okay, within 2 weeks, as already mentioned. For those 2 weeks, you will use antiplatelet therapy from the initial event. Okay, it aims to reduce the recurrent stroke risk with no impact on the outcome of the initial stroke. Remember that. Why do we treat the patients within 2 weeks? Because they say that the incidence of stroke, okay, the incidence of stroke after the initial TIA is highest within first 6 weeks. So wouldn't want to exceed that. Therefore, we have to go for the treatment within 2 weeks. Okay, within 2 weeks. Done. Before leaving, I want to mention one of the last point, and we'll continue tomorrow, and that is 5 Ws of post-operative fever. Anyone from you who can tell me what are the 5 Ws of post-operative fever? Starting from first W. Okay, I will just write 5 over here, and you will tell me what does each W stand for.
First one is wind. Wind for wind for pneumonia.
Yes.
Sorry, yeah, pneumothorax, something like that. And second one is wound.
Wind, and then is water. Okay.
Sorry,
Then
wind, water, and wound.
wound is over here.
Sorry, the third one is walk.
Okay, third one is walk.
Yeah, thrombosis kind of things.
And last one is
wonders. So wonders mean drugs, drug interaction,
yes.
something.
Wonder is basically like, okay, start with the wind. What are the differential? Patient coming to you with the patient had a recent surgical procedure, and within 24 hours, the patient come with the fever. Now, first, yes, atelectasis, exactly, atelectasis. Tell me what is the treatment for atelectasis?
Physiotherapy, like stepwise approach should be done. Like first is chest compression. Sorry, the physiotherapy.
Yes, just remember about the physiotherapy. Okay, physiotherapy. Okay, physiotherapy. Go for the physiotherapy. You use the You use the intensive spirometry. Have you seen that? Simple. There are like 3 balls, and there is this pipe, and I want the patient to just lift these as much as possible. Okay, to the highest level. Okay, this is the patient, and now he will just blow through this. This is used for the patients who have atelectasis. So you have, yes, if there is no improvement, enrollment, you go for the suction. Now, after the atelectasis, what could be the other reason? Aspiration. Okay, aspiration is another reason. And even pneumonia is also present in the wind part. Okay, wind part. First is atelectasis, aspiration, pneumonia. For all these reasons, look at the X-ray. Okay, check the X-ray. Now, water. Water is UTI. Other reason can be thrombophlebitis. Okay, thrombophlebitis. It is basically near the catheter region. There could be the inflammation of the veins and all, and that could be one of the reasons resulting in post-op fever after 24 hours, like on the second day. Third day, now there is a third day, that is your DVT. Okay, that is work is none other than DVT, or it could be pulmonary embolism, right? Pulmonary embolism or DVT. Patient will have this cough, pain, or the patient can have chest tightness, basically due to the pulmonary embolism. If you remember the Wells criteria for both the DVT and the pulmonary embolism, BD CHIPS is the mnemonic, and one of them is if the patient has a recent surgery within 4 weeks. Okay, and that could be one of the reasons for the pulmonary embolism or the DVT. Then W is wound, and it basically comes on 5 to 7 days. It could be wound infection. What is the most common cause of wound infection? Surgical site infection. Staph, right? Staph aureus. So wound infection mostly caused by Staph aureus. Okay, I was talking about now. Have you checked out one important point which I have written over here? Anastomotic leak. If there is any patient, if there's any patient, we'll tomorrow discuss about the esophageal carcinoma. Okay, when we talk about the esophageal carcinoma, and some patient need to go for the surgery. Like for example, there is a patient who is having stage 1, 2, 3, 1 to 3. Any patient who is having esophageal carcinoma, even if it is stage 1, 2, or 3, we have to go for the esophagectomy. Right now, if you go for the esophagectomy, after doing esophagectomy, and the patient is coming up to you after 5 to 7 days with signs symptoms of fever, tachycardia, with increased respiratory rate, and there is cough with the patient is having cough, and the patient is telling you that whatever I'm coughing, okay, whatever I'm coughing, I'm aspirating that. Okay, or we can say the patient will tell you, doctor, whatever I eat, I'm coughing that out. So any patient who went for the esophagectomy, okay, after 5 to 7 days, coming up with fever, heart rate, and respiratory rate elevated, please make sure you have ruled out what? Anastomotic leak. This is the possibility. You don't look for the wound infection or abscess. This is the possibility for anastomotic leak. Done. Then what is the last one? It is due to the drug. This is the drug induced fever, and this is the diagnosis of exclusion. This is the diagnosis of exclusion. Now, that's it for today. And tomorrow, the first topic which we'll discuss it is the delay of puberty. Okay, delay of puberty is what we'll discuss tomorrow. Tomorrow we'll discuss more of the pediatrics. Okay, pediatrics. We will discuss some of the important topics of pediatrics and some important topics of gynecology, obs-gyne. Okay, more of obs-gyne. Okay, take care. Yes.
Yeah, actually, I have a doubt regarding uh, the CTPA, like a pulmonary embolism.
Okay. Yes.
It's not from this lecture actually. So
Okay.
in pulmonary embolism, especially in the pregnancy.
Mm-hmm.
So, if they ask what is the most appropriate diagnostic test, that means CTPA, right? Like, is it CTPA or VQ
Yes.
scan? Like you
Yes,
said,
yes, yes, yes. I got
from
it. I
most,
got it. See, I
yeah,
got it. What you are asking for. This has been the discussion from last 1 decade. Like, should we use the CTP or not? See, I have read the SOMA's guidelines. I know in the therapeutic guidelines they have written over that we can use CTPA in a patient who is pregnant and is having pulmonary embolism. But in here in Australia, if you see that they read they are more towards the SOMA's guidelines. They prefer SOMA's guidelines because SOMA's guidelines is more for the uh, women's healthcare. Okay, and they have clearly mentioned that CTPA is used in those who have what do we say is that who are unstable. Okay, those who are unstable. Okay, you can go for the CTPA. Other than that, if they ask about the most appropriate, remember this. If they ask about the most appropriate, according to therapeutic guidelines, it is still CTPA. Now, if they ask about most appropriate next step, okay, most appropriate next step, and they have already, remember one trick in the question. If they have already mentioned that X-ray is normal, okay, then you will go for VQ scan. There is no use of D-dimers in pregnancy. Okay, there is no
yeah,
use of D-dimers in pregnancy. Number one, if they will give you the question, they provided you the question, and they have not mentioned anything about X-ray. Okay, they have not mentioned anything about X-ray. Go for the CTPA. If they have mentioned about the CTPA, if they have mentioned about the X-ray, and they have written that the X-ray is normal, that means they are they are helping you out that it
like
is,
they are guiding.
yeah,
Yeah,
you have to go for the VQ scan rather than the CTPA. If they have not mentioned anything about X-ray, go for the CTPA. If in the stem they have mentioned about the X-ray and that is normal, if it is abnormal, again you will go for CTPA.
yeah, CT.
Done with this. VQ scan, look at the X-ray. For the usage of VQ scan, the X-ray should be normal because VQ
Yeah, it's a
scan,
prerequisite.
yes, this is how you'll approach a case of pulmonary embolism with a suspected case of pulmonary embolism in pregnancy. You can just, yeah, I will just share this PDF along with the yesterday's PDF. So with that, if you have any, uh, if there's any topic which you want me to discuss, please let me know. I will include that in my next classes. So, yeah.
And Doctor, one just a small doubt.
Yes.
The regarding meningitis, like
Mm-hmm.
I always have a confusion regarding the LP and blood cultures.
Yes.
So, like when the patient presented with the meningitis condition, do we first we need to antibiotics is important, right? So
Yes.
then we'll go for blood culture, take the blood culture and
Mm-hmm.
give the antibiotics, IV
Yes. Yes.
antibiotics. So when do we do the LP?
I will tell you.
Sometimes,
For
yeah,
the meningitis, one of the most important point for the meningitis is securing the IV line. Okay, that is the first thing. Forget about the blood culture and all. Don't take blood culture if you don't have time. Okay, go for the
okay,
antibiotics directly. Then take the blood culture. Okay, once you go for the IV line, give the antibiotics, take the blood culture. Now they will ask you about whether we should go for now the lumbar puncture or the CT scan. Remember, if there are neurological symptoms like the patient has papilla, that is what do we call that, papilledema. Okay, on fundoscopy. They can mention this, okay? Papilledema on the fundoscopy, number one. Or the patient is having severe headache, okay? The patient is having severe headache. Number three, the patient is having projectile vomiting. What does that mean? What does these three mean? These three mean that the patient has raised ICP. And all those patients who have raised ICP, we cannot go for the lumbar puncture because it can result in what?
Hernia?
Yes,
Yeah,
it can result in uncle hernia, right?
uncle. Yeah.
And the patient can die because if you remember that uh, if you can remember that if this is the cerebrum, if this is the cerebrum, we have the midbrain, then we have the pons, and we have medulla oblongata, then we have this spinal cord, right? Here in between the pons and the medulla oblongata, we have one pacemaker for the respiration, right? What is that called as? Back to physiology. Preborzinger complex, right? This Preborzinger complex is responsible for the starting of respiration. Okay, we are able to do the respiration with the help of this pacemaker of a respiratory system, that is Preborzinger complex, which is present between pons and the medulla oblongata. And what do we have here? We have the cerebellum, right? Say for example, if there is increased ICP, okay, in the because in the meningitis there is inflammation of these meninges, and now there is raised ICP. Due to this raised ICP, there is now if you go for what? Lumbar puncture. If you directly go for the lumbar puncture, this part of the brain, it will go down, and it can press this Preborzinger complex, and the respiratory respiration will be seized, and the patient will die. So that is the reason we don't go for the lumbar puncture in all those patients who have suspected raised intracranial pressure. So we don't go for lumbar puncture in those. There are other, like for example, the patient is having any the patient is having any bleeding disorder and all, or the patient is having stenosis, the patient is having any tumor in the spinal cord, syringomyelia. For all those reasons, we don't go for the lumbar puncture. And one of them is raised ICP with meningitis. You don't go for the lumbar puncture, so you have to go for the CT scan. Once you go for the CT scan, you look at, you rule out the raised ICP, right? You check the lateral ventricles if they are dilated or not. Okay, and if it is normal after using CT scan, if it is normal, then yeah, you can go for the lumbar puncture. But yeah, never ever go for the lumbar puncture in all those cases who have raised ICP. If you read the guidelines, sometimes they say that after you do CT scan, you can use dexamethasone, because dexamethasone is it decrease the vasogenic edema. Once the vasogenic edema is decreased, then you can go for the lumbar puncture. Okay, then you can go for the lumbar puncture. You go for the CT scan followed by dexamethasone. There's decrease of the vasogenic edema. There's decrease in the ICP. Then you can go for the lumbar puncture. So this is our meningitis, IV line, antibiotics, blood culture. Check this raised ICP. If there's raised ICP sign symptoms like the papilledema, severe headache, projectile vomiting, go for the CT scan. Don't go for the lumbar puncture. CT scan is normal, or it rules out raised ICP. You can go for the lumbar puncture. Done?
Yeah, thank you.
Okay, thank you so much for like joining this session, and make sure if you have any topic or you want me to discuss any topic tomorrow, just let me know, and hopefully we'll just finish up each and every important topic. The main reason is learning about the important topics, and once we are urolithiasis, yeah, again very important. It's very confusing, right? So let me assure you that once you read the urolithiasis from tomorrow's session, I will add up, you can never ever see any question which will be difficult for you to solve. Okay. Thank you so much for joining this session, and take care. Bye bye. And